Welcome to everybody and welcome to those online as well. My job is to set the scene and let's have a look at the factors that are influencing food intake in older adults. And obviously if the factors are influencing their food intake, these factors are also influencing their risk of malnutrition. Just to give you an idea of the agenda today, we're going to look at why aging impacts on nutritional status. We're going to look at the consequences of this. Then we're going to turn to the key barriers that are facing us when we try to improve nutrition in older adults. We're going to look at some nutritional interventions and particularly the key aspects of that, things that we should remember if we're intervening ourselves in our clinical practice. And then finally, we're going to look at compliance. So aging impacts on nutritional status in many diverse ways, and this very complicated triangle really boils down to three key things in the centre. There are three principal conditions that affect an older adult's ability to maintain their nutritional status, and that is having a low intake of food and nutrition. That is having high requirements. It could be not just for energy, but for protein and micronutrients. And then finally, it is the impaired bioavailability of those nutrients. And that is at the centre of this. And then as you can see, the triangle builds out to the very complicated areas of their personal lives, their social situation, their medical conditions, that are all impacting, but it all really boils down to the three principal conditions. So if you only remember one thing about that slide, it is the centre part of the triangle. We're going to do some focuses now on certain areas of this. One is changing requirements. So one of the things that influences nutrition as people get older is that their energy intake can often reduce as they become less physically active, less hungry. They are perhaps sitting for longer, and so they're not eating so much food, and their energy requirements go down. However, their protein requirements actually go up on a body weight basis compared with younger adults, not children, but younger adults. And the reason that the protein requirements go up is that we're trying to protect the lean body mass, the muscle. Vitamin and mineral needs typically stay the same. Perhaps they have an enhanced need for certain immunity nutrients, for example, vitamin D. They might have an enhanced need for antioxidants. They certainly have similar fibre needs because we have to maintain a healthy balance of gut microbiota. So that makes me think that every bite counts for an older adult. They can't afford to waste their food energy on something like cakes and biscuits, which are very light on nutrients. I mentioned bioavailability. Here's a nice study which gave a standardized amount of micronutrients in a vitamin and mineral supplement along with a standard meal to older adults and younger adults. And what they found was that there were some differences in bioavailability. If you look at the charts, we can see the older adults are in black, the younger adults are in blue, and there is a slower response to the intake of, for example, we've got copper, selenium, and iodine. And as you can see, a very slow response of the older adults, which then dropped off quite quickly. And this is their blood levels in response to a standard amount of those nutrients. Other nutrients had similar absorption. This was just one study, and this is the type of study I would actually like to see repeated, because I wonder if there are some differences for the other nutrients, for example, vitamin D. So the consequences of this, of having a higher requirement for certain nutrients and having a lower intake, is that you have a greater risk of malnutrition. That then has an impact on the older adults' muscle mass, their muscle power, their risk of falling, their bone density starts to decline, and they have an overall poor nutritional status. They also have a reduced diversity of gut microbiota. That is not just related to the dietary intake, but related to the effects of aging as well. So let's have a look at malnutrition. A shocking statistic is that more than a quarter of older adults in hospital are at risk of malnutrition. That is a huge amount of people, and I guess what we're experiencing at the moment is the twin effects of some older adults actually have obesity and quite a lot have malnutrition. So it's a very kind of polarised situation from a nutritional context. We see that there's lower risk of malnutrition, but still fairly high in people living in residential care versus the community where you've got just under 10%. And the consequences of malnutrition is not a kind of a benign thing. It actually has a serious impact on the ability of an older adult to get well if they happen to be in hospital. So you're looking at longer hospital stays, you're looking at greater healthcare inputs, greater healthcare costs, increased frailty. So when they're sent back from hospital to their own home, they're much more likely to fall again, get ill again, and end up back in hospital. So really, I think in the past, maybe 20, 30 years ago, when I was first training as a dietitian, malnutrition was seen as, yeah, well, we know it's there, but, you know, we do try our hardest. Now it's changed to we must deal with this. We must find it, we must assess it, and we must deal with it early, because that saves costs and it also saves the patient's experience of hospital. It saves it from being a negative experience. They can get home and they can get back to their normal lives if we can fix malnutrition. And malnutrition isn't just about energy and nutrients, it's also about protein and loss of muscle mass. So here's a study where we've got healthy elderly and we've got elderly with already pre-existing conditions and reduced mobility. And as we can see, when we look at their peak power, the healthy elderly are declining over a 3-year period, and the decline is actually similar to the elderly who already had health problems. But what we can see is this huge gap between elderly who already have existing health problems. So they are starting at a lower level and it's only going to get worse. And the problem with muscle mass decline, which operates at around 0.6 to 1% a year after the age of 75, is it hugely increases the risk of falling. And falling and having a fracture and ending up in hospital is often the beginning of a lot of trouble for elderly people. So they end up in hospital, they maybe then have an infection, they then spend ages in hospital, nobody can look after them at home, they block the bed, and you then have a series of issues that have all started because that person's muscle mass has declined to a very low level. And vitamin D status is part of this as well. If people have a low vitamin D status, they're at increased risk of falling. Now, the shocking thing about muscle mass decline that I discovered is if you have a period of immobility, for example, if you have maybe a health condition, have to go to bed for a couple of weeks, it could be a respiratory infection, that muscle decline then gets faster. So anything that involves elderly people having to have bed rest or they're ill will actually make the muscle mass decline even faster. So now let's look at fixing the problem, but we have to face the barriers first. Now I've highlighted 4 barriers here. One is physiological barriers, psychological barriers, disease-related barriers, and of course treatment is part of that, and then finally social. So I'm just going to take each of these at a time. So physiological, I mentioned already that elderly people tend to be less hungry, particularly if they're very sedentary. So they will eat less food. They will perhaps have early satiety where they get full quicker. That means you need to give them smaller portions, more energy-dense foods. They could have an altered sensory perception that perhaps, for example, they don't feel thirst as strongly as younger people. They might prefer sweet foods and not be able to taste some of the more complex tastes in food. They might have fatigue, which means that they're then too tired to eat a full meal. And they also might have lower gastric motility, which means that the food is not emptying out of the stomach quickly enough, and that also makes them feel full. They have constipation quite a lot of the time as well, which is related to the immobility, and that can reduce appetite. So there's some physiological things that affect appetite and food consumption. We've then got the psychological, and now we're bringing in cognitive dysfunction, Alzheimer's, dementia, just cognitive declines such as memory issues, stress and anxiety, And even things like fear of incontinence, because older people can sometimes resist, for example, drinking, because they're worried about having to go to the toilet and having a urinary urgency. They might also worry about either constipation or even diarrhea. You sometimes get elderly who have irritable bowel, where they might get anxious and then need to go to the toilet fast, and that can put them off eating certain foods. On the disease and treatment side, we've got obviously the big one, which is pain. If you're in pain, you're not going to be hungry and wanting to sit down and eat a meal. You might have treatment effects such as anorexic effects of drugs, even drugs that cause constipation. If you are doing a lot of investigations with older people, they might have to be nil by mouth or have restrictive diets, and that certainly has an impact on their ability to meet their nutritional needs. Certain treatments, for example, radiotherapy for head and neck cancer, can affect their perception of taste and smell. So quite often foods will then taste unpleasant. So if they're receiving certain treatments, certain medical treatments, that could actually create barriers to food consumption. So looking at the final one now, which is the social, this is things like loneliness, which is a big problem now with so many, we've got an aging population, so there's so many older people now that are living alone and might even have family who are living in a different country. And so you've got loneliness. When people live alone, they can't be bothered cooking and eating. They might just snack. They might just go for easy options which are less nutrient dense. You've got to think how they can get to the shops, how they can cook. And certainly there's lots of solutions to that through things like occupational therapy and nursing at home that can help these people. Also things that are happening in the community. For example, meal. We have at our church an event on Monday lunchtime when people can go to the church and eat a hot meal, and we get quite a lot of elderly going along to that. So there are solutions to these social problems. So turning now to nutritional interventions in older people, the goals here are to meet their needs, particularly their protein and micronutrient needs. I mentioned protein requirements were slightly higher in older people, and here we're looking at around about 1.2 to 2 grams per kilogram body weight to try and maintain that muscle mass. The protein has to work a lot harder in older people because they're less physically active. If we can combine this with resistance training, even chair-based resistance training, that can help the protein get into the muscles and do its job. We need to reverse unintended weight loss, and that involves a lot of assessment over time of these patients. We need to improve muscle mass and function, so that's going back to the resistance training. And then we need to correct any deficiencies, which might either be through an ONS, a multi-nutrient supplement, or you might even need a prescription for things like B12 or iron. Vitamin D as well can sometimes get very low if people are housebound. So we've got the ESPN guideline here, which I'm going to focus on in a minute in relation to ONS, but they have key things that we need to be thinking about when intervening with patients. The main one is screening, because if you don't know what's going on and you're not following them up over time, then you can't see those changes that are then bringing about a decline in nutritional status, which will end up in malnutrition. There's no point waiting until they look skeletal before you do anything. You need to start assessment early and doing it on a regular basis so you can spot those declines in, for example, things like weight, or you might do a muscle mass check with an upper arm circumference. And ESPN also mentions things like education and food modification, and particularly mentions ONS. So it's certainly worth having a look at this guideline. As a dietitian, of course, I always put food first. So I'm a great fan of ONS, but it has to sit in a context where food is the cornerstone, and that is making sure older people can get a healthy, balanced diet, that they're eating socially, and that could be through things like Meals on Wheels. And you add the ONS if these nutritional goals are not being reached with food first. So the strongest evidence is for ONS, and that's probably just because of the huge number of studies that have been done, and because it's a much easier intervention to standardize than food, which can obviously vary a lot. Here's a study which says that nutritional interventions have a positive impact on energy intake and body weight, and dietary counselling combined with ONS is the most effective intervention. So that is certainly worth having a look at that study, which was brought together randomised controlled trials on nearly 1,000 older adults. So I mentioned the ONS guidelines in ESPN. Here they are. I'm not going to go through them all because of time, but I'm certainly happy if anyone wants my slides at the end to come and approach me. And also I know that Nestle are going to be videoing this. So certainly have a look at this ESPN guideline for these particular guidance notes relating to ONS, which gives you guidance on counselling, the amount of calories to go for, and how long to continue it for, and when to do a follow-up assessment. But the most important thing when giving ONS is compliance, because if a food is not eaten, it is not doing any good. So we have to make sure that older people who are given an ONS prescription are able to access it and consume it, and we know how much they're consuming. We're actually monitoring it, because non-compliance with ONS prescriptions ranges from 0 to 63%, with an average, and this is based on 46 studies, of 22%. Now, that is not only a waste of calories and nutrients for the patients involved, but it's a waste of your hospital budgets to spend money on this. So we really need to make sure that people are taking their prescription. And as we can see, the non-compliance was higher, 33% in hospital settings. So when you think how many staff we've got in hospitals compared with somebody in their home, we really need to do more to make sure people are having their ONS and we're following it up. There's a number of factors influencing ONS compliance, though, which we're very much aware of. Some relate to the ONS itself and making sure that patients are having the one that's right for them. Some relate to the amount of fluid that you're trying to get into somebody. So again, there's the more energy-dense options available to make sure that you can have a lower volume. And palatability is a big issue, but again, it's about letting your patients try different types and make sure they get the one that's right for them. There was an interesting focus group that was just published this year looking at patients' experience of ONS, and one surprised me, which was patients sometimes believe, this is older adults, that if they're getting ONS, it's because they're getting end-of-life care. And I think that's something that we can help with a lot as healthcare professionals, that when we're giving somebody some ONS, we're not saying, oh dear, you're not eating very well, here you go, this is for you. But we actually explain it in a positive way. Just say, if you take this, it's going to help your energy levels, it's going to help your nutrition, you're going to feel better, and really try and sell it in a positive way to patients. And I think that would very much get over this barrier of patients thinking, oh no, I'm now going to be put in death's waiting room because I'm getting this ONS. That's just simply not true. It's a tool just like medicine. Also, things like reminders was a big problem. So again, it's working with your patients to find ways, whether they have it, as soon as they get up in the morning, or maybe when they're watching a certain television program. So there's ways that we can overcome this. So just to conclude then, and please refer to the abstract for more details on all of this. It's all in there. We need to understand that as we get older, our nutritional status is going to suffer at some point, and it's about heading that off early through monitoring. The ESPN guidelines are a fantastic resource to go to in your practice. We need to intervene with malnutrition early before it comes too late. And part of that is getting the compliance right, helping our patients and working with our patients to ensure that they're taking their ONS prescription and that they're feeling the benefit of it. So thank you very much for your attention, and I look forward to your questions.